Our first paper is being presented by Dr. Shannon Larrabee from Texas Children's Hospital. She will be discussing changes in healthcare utilization and surgical needs of infants in Texas following the early abortion ban, and our discussant will be Dr. Mary Brandt.
All right. Sorry, does the script come up here? Sorry.
It should. Is it not? Nothing?
Currently, there's nothing.
It should be presented.
All right. It's not here. For the presenter mode, the text.
Can we have the screen on?
Okay. Thank you. All right.
There we go.
Thank you. Sorry about that, everyone. All right. Thank you for this ability to talk, and we have nothing to disclose. So congenital anomalies impact approximately 3% of U.S. births annually, ranging from polydactyly to complex conditions such as omphaloceles and congenital heart defects. If detected prenatally, the decision to electively terminate a pregnancy for an anomaly is complex. In September of 2021, Texas passed Senate Bill 8, also known as SB 8, which banned early abortions in Texas. Since then, we wanted to be able to evaluate what the state of surgical utilization in this infant population has been in the state of Texas. We use the Texas Inpatient Public Use Database, a statewide hospital database to evaluate infant admissions from 1 year pre-SB 8, 1 year during our transition period, and 1 year post-SB 8. This was done such that pregnancies were conceived and completed in each study period. All patients under 1 year of age at discharge were included, and ICD-10 codes were used to identify our patient population. We did not include patients transferred to an outside hospital to prevent systematic double counting. In our study, we identified over 1 million infant inpatient admissions with over 170,000 admissions for patients with congenital anomalies. Post-SB 8, all infant admissions increased by 9%, with a disproportionate increase in congenital anomaly admissions by 25%. All operative admissions increased by only 1%, while operative anomaly admissions increased by 9%. Graphed by quarter across our study period, the increase in congenital anomaly operations grows from 17.5% of all operations to 18.9% of operations post-SB 8. This increasing trend in congenital anomaly admissions equates to a 15% overall population of congenital anomalies in operative patients during our study period. However, this comprises 65% of operative admission charges, $7.4 billion out of the $11.4 billion charged during this study period. This is an increase of $657 million in congenital anomaly operative admission charges post-SB 8. Looking further, post-SB 8, congenital anomaly and non-anomaly admission charges increased by a median of $600, while operative charges decrease for patients without an anomaly and increase for those with an anomaly by a median of $2,000. There were no differences in median length of stay for all patients across all periods of our study, although there was more variability for patients with congenital anomalies requiring operative admissions. Statistically, overall, mortality and congenital anomaly mortality rates were stable across the study period. In operative admissions, overall and non-anomaly patients had a decrease in mortality, while congenital anomaly patients saw an 11% increase in mortality. To further evaluate the rates of specific anomaly categories as a proctor for likely surgical services needed, ICD-10 diagnostic codes were broken down into their predefined organ system groupings for further analysis. This showed a global increase in anomalies post-SB 8, with a 15% or greater increase in CNS, ENT, cardiac, urinary, and and congenital anomalies, Concurrently, there was an increase in operative admissions in CNS, cardiac, pulmonary, genital, urinary admissions, while there was a decrease in musculoskeletal operative admissions. We acknowledge that this data set has limitations, including the inability to track patients longitudinally and the inability to correlate any prenatal diagnoses with our patients. However, the study of infant care during the first year of life demonstrates an increase in 1,000 births with congenital anomalies requiring operative intervention and an increase in anomaly operative admission charges by $657 million post-SB 8. This increase in charges is an indicator for future planning needs for operative services across multiple different specialties, and additionally, what are these healthcare needs of these children outside of the hospital? Thank you. I'd like to thank my lab, and I will ask for any questions.
Mohammed Emran, Corpus Christi, Texas. Thank you for this presentation. I think this highlights a really big problem that we have nationwide, and I think one of the problems that we have is not so much the issue of abortion, but the ethics of what do we do for fetal care after a baby who has considerable congenital anomalies that we have no hope of fixing, but we still go through the motions of doing all these operations. And have you guys started looking at addressing some of those issues?
So,
Can we hold on to answering that question? Dr. Brand is going to present her discussion of the paper. Thank you.
sorry, then I will wait.
No, I just wanted to add that I think in this very complex, and certainly as a Texan, I can say extremely complex environment we live in, all the data we can gather to help us be reasonable and to eliminate suffering is important. And so although the cost, and you've done a wonderful job showing that, is dramatic and we need to share that data, what you've really done is take a very volatile thing in our society and said, wait a minute, let's look at it from all these different angles. So I really appreciate what you've done, and I thank you for doing it.
Thank you. For the previous question, that is unfortunately something that we cannot associate with our data set, as this is all completely anonymized, but it is something that is important to the overall discussion of these infants' cares.
Thank you very much. In the interest of time, we have to move on. Our next paper is preoperative considerations and early outcomes in gastrojejunostomy tube placement versus fundoplication for treatment of gastroesophageal reflux, results from a multi-institutional research collaborative presented by Dr. Tanya Ganel, who's a pediatric surgery research fellow at the Stanley Children's Hospital, Columbia University. Thank you. Can we move on to the next slides? Yeah.
All right, good morning. Thank you so much for the opportunity to present our results from a multi-institutional research collaborative on behalf of the Eastern Pediatric Surgery Network. There is no standardized way to really decide whether a child gets a Nissen fundoplication or any sort of gastrojejunostomy tube for medically refractory GERD. Given that, the purpose of our study was to build a retrospective chart review of patients within the 14 hospitals within the EPSN to look at patients that underwent surgical intervention for their GERD. That said, the primary outcome was to evaluate how preoperative symptoms determine choice of anti-reflux procedure. Secondarily, we looked at how patients that underwent fundoplication or gastrojejunostomy tube did in the 30-day postoperative period. The patients that were included were children aged 3 or younger that underwent surgical treatment for GERD from 2010 to 2020. Children that had any sort of contraindication to an anti-reflux procedure were excluded. We noted that when we looked at our demographic information, we had about 1,400 patients, the majority of those being Nissen fundoplications, and 180, the remainder being gastrojejunostomy tube placements. Older children and those of a higher weight were more likely to undergo GJ. There was a significant difference in more premature infants undergoing Nissen, and also when we looked at race, babies or children that were Black tended to go, or unknown race, excuse me, tended to have a Nissen, while white infants underwent more GJs. Keeping in line with those trends, more NICU patients underwent Nissen fundoplication. We also evaluated underlying conditions and comorbidities, which were all skewed toward gastrojejunostomy tube as well. We see here that children that had an existing gastrostomy, any GI condition or genetic disorder underwent GJ placement. We looked at the preoperative symptoms as well, just to loop back to our primary outcome, and we noted that children that presented with vomiting, aspiration, pneumonia underwent gastrojejunostomy tube placement over Nissen. However, infants that had failure to thrive tended to undergo Nissen fundoplication, which was significantly different. Lastly, we looked at 30-day outcomes as mentioned and noted that the children that had fundoplication had a significantly longer length of stay. However, when we looked at the other complications, bleeding, reoperation, or need for other sedated procedure, shock, sepsis, hematoma, postoperative respiratory failure, or other sort of complication, those all tended to occur in the GJ group. I know that we had talked about how there was no sort of standardization of choosing procedure for medically refractory GERD in children, and we wanted to really evaluate why these choices were made and which factors might play a role. We did note that several factors may contribute to a choice of procedure for an anti-reflux surgery. There, of course, is likely an institutional bias, and that is part of the multi-center collaborative as well that we have. We noted that older and more complicated patients are undergoing GJ with more underlying conditions. There seem to be more early complications in this group. However, there was no difference in choice between those with neurologic and cardiac comorbidities. Given this tendency for more complications in GJ patients, there needs to be a further analysis and matching of cohorts. This brings me to our limitations and future directions. I briefly touched upon the institutional variability of practice, and so we had a previous analysis actually that we built a multivariate model and added hospital as a random variable to be able to control for this possible bias. And however, those results were still significantly different. We aim to use propensity score matching to compare patient populations that are more comparable. And also, I know there's a pretty large discrepancy in our sample size between those arms. Some of the hospitals that we included in our research collaborative tend to only do Nissens, which really does skew the data. And so our hope is to use inverse treatment of probability weighting to be able to construct a balanced patient population that can actually be compared then. And lastly, I think that this sets us up to really look at the effectiveness of a Nissen fundoplication versus a gastrojejunostomy tube and placement and treatment of GERD. Thank you so much.
Paper will be discussed by Dr. Whit Holcomb.
Whit Holcomb, Nashville. Tanya, very nice report. I know you and your co-authors spent a lot of time gathering this data, and there's some really good information in there. I think, as you know from prior correspondence, I have concerns about the bias really between one institution versus another institution, because I think we all know that some institutions are pro GJ tube and some institutions are pro fundoplication. But I think nevertheless that this is a nice study to start the conversation about a future trial that's more prospective in nature. So congratulations on your nice study. Thanks.
Thank you.
Yeah, I also had a question about whether you can somehow factor in parental bias and social media and impact that makes.
Yeah, that's a great point. I actually hadn't thought about that. I know that I kind of thought about sort of child opportunity index and previous sort of social determinants of health and figuring out if there was any sort of relationship between a choice of procedure there. We had a previous analysis too that incorporated that and showed that lower child opportunity index tended to get Nissens rather than GJs, and so I wonder if there's also some bias from a socioeconomic status level. Thank you.
One of the things I always thought was very strange was that we get patients with Nissens who then get GJs. And you wonder, is the Nissen really working to the goal that they have if we're switching to a GJ and using GJs? I know this is your initial choice of procedure, but I think looking at the same group and crossover, who from the GJ group went on to get a Nissen, and who with a Nissen at a pro-Nissen institution went on to get a GJ, might be a good way to tackle the bias.
That's a fantastic point, and we actually do have a smaller group for those that were converted, but I don't think it was significant. But hopefully with the rest of our data, we'll be able to incorporate that. Thank you.
We have time for one more question.
Hi, good morning, Talia. Thanks for a great talk. Alex Gibbons, a fellow from Phoenix Children's. I saw that you mentioned that the GJ patients had a slightly higher weight than the Nissen fundoplication patients. And I know that this was a multi-institutional retrospective study, but was there kind of a minimum cutoff of weight for patients who would be getting the GJs?
I don't think there was a minimum weight. I know that we had another analysis, also preliminary, that showed that the lower weights than the typical was used for a GJ. You know, I know that there's a lot of evidence that lower weights leads to perforation, that sort of thing. And in our previous analysis, we didn't have that, but we did not have a specific cutoff to answer your question.
Thank you very much.
Thank you.
Our next paper is Teenager Appendicitis, the Cost of a Transfer. And this will be presented by Dr. Jennifer Hsu, and we will have a discussant as well.
Good morning, and thank you. We did this research because I found that overnight, when being paged about a 17-and-a-half-year-old potential appendicitis transfer is not always the most optimal time to have this conversation. Healthcare resource utilization is important, including cost. Many in this room will remember Dr. Oldham's 2015 presidential address titled after the 1983 film, The Right Stuff, which focused on a recent initiative by APSA and ACS to get every child who needs surgery the right stuff. The appropriate level of care, hospital resources, and staffing. The initiative coincided with a significant trend toward regionalization. However, we also must make sure we aren't shipping children across the state if the right stuff exists in their own backyard. This regionalization trend is especially apparent in appendicitis treatment. The benefit to those less than 5 years old of being treated at a children's hospital has been demonstrated. However, for 6 to 18-year-olds, no benefit has been substantiated, but the trend towards regionalization permeates this age group as well. We aim to determine the frequency of teenage appendicitis transfers within Wisconsin and compare the total associated charges of transferred teenagers to those who weren't transferred. We utilized a database of all submitted insurance claims in the state of Wisconsin from 2017 to 2022 and included all children who had a CPT code for an appendectomy. Claims were limited to 1 week before the appendectomy and 30 days after the surgery. Transfers were defined as those patients who had facility charges from at least 2 facilities within 2 days of the operative claim, both of which have surgical capabilities, which we defined as at least 10 appendectomies in patients of any age within the study time frame. Average total charges were compared after inflation adjustments between patients who were transferred versus not transferred with a Wilcoxon rank sum test. Charges included those associated with the operation, hospitalization, ambulance charges, and pharmacy charges. 5,794 children within Wisconsin insurance had appendectomies. 18% of those patients were transferred prior to their operation. You can see that a higher percentage of transfers occurred among the younger patients, as you would expect. However, this curve is not nearly as steep as we expected. Among those patients greater than 12 years old, the median cost to transferred patients was $49,000 instead of $39,000 to those not transferred. 14% of this age cohort was transferred. That means that over the 6 included years, over $4 million was spent on transferring teenagers with appendicitis. So what's driving these transfers? Is it geography? The short answer is no. On the left is a frequency map of occurrences of appendectomies among all children, excluding the 4 Wisconsin zip codes where pediatric surgeons operate, which are marked with stars. In other words, this is a map of general surgeons who are performing pediatric appendectomies, with the larger, darker purple dots representing more patients. And on the right are where teenagers are being transferred from, the origin of transfers. Basically, the left shows all the places capable of doing pediatric appendectomies, and the right are the places choosing not to operate on teenagers. You can see that these transfers are not just coming from one or two institutions, and not just across town, but really are coming from all over the state. The overlap between the two maps suggests that many institutions are transferring some, but not all, of their pediatric patients. So what's driving the transfers? We performed a multivariate logistic regression, which revealed that younger age and public insurance are significantly predictive of transfer. Specifically, 21% of those with public insurance versus 9% of those with commercial insurance are transferred. The study is inherently limited. The ages of all patients are set to July 1 of their birth year, and we were exclusive with our data, so our results are likely underestimates. We don't capture medically managed patients. The database does not have a way to differentiate simple versus perforated appendicitis. Additionally, capturing all charges 1 week prior to the procedure and 30 days after the procedure likely includes some irrelevant charges and may exclude some relevant charges. Finally, when we capture the charges, we cannot capture the actual reimbursement or actual cost to the patient. Our next steps include geospatially analyzing the transferred patients, looking in detail at other factors that may influence whether patients are transferred, including area deprivation index and rural residents, and doing an analysis of the transfer rates over time. In conclusion, we found significantly increased costs charged to transferred patients, and each teenage patient incurred an additional average of nearly 10 grand for a total of over 4 million spent. It's important to remember that the extra charges are just one factor in the equation. In addition to the raw charges, transfers may also mandate temporary caregiver relocation, time away from work, arranging sibling child care, among other social considerations. Thank you for your attention. I'm happy to take any questions.
Thank you. We'll open with comments from Dr. Weiss.
Yeah, thank you. This is an important paper on a topic that we typically as pediatric surgeons don't hear much about, which is the cost of the care we render, in this case, the cost of a transfer from a hospital in the so-called periphery to a specialized center. Of course, this is the second paper we've heard about cost today, but this is a practice pattern problem that you've shown, whereas the other paper was more on a policy change. So cost is certainly an important problem for all of society, and I think most of us know that the costs in the United States are significantly higher for healthcare than the costs elsewhere, including here in Canada. So when looking at charges in the state of Wisconsin, you found that per patient, when you looked at 12 and up, it's $9,000 per patient who is transferred. When you looked at 15 and up, it was $7,000 more per patient. And as you point out, charges are not reimbursements. The actual cost will be somewhat less, but it's still going to be increased. How much less depends on the payer, commercial or Medicaid. You did mention Medicaid in your talk, and we all know that Medicaid will reimburse the least of all the payers. So the only intuitive benefit to a transfer is the likely improved environment of care provided in the pediatric center with surgeons, anesthesiologists, nurses, child life, and others all focused on the psychosocial needs of the teen patient and family. And that leaves the open question, is it worth it? Given that there's increased cost and parent or caregiver inconvenience, and you mentioned in your paper that there is significant inconvenience, and in the state of Wisconsin, which is not a small state like Connecticut where I am, they're traveling quite a distance and leaving children behind and leaving their jobs behind, so there's increased cost to them as well. So I have a couple of questions, some of which you actually answered already. What are the differences between the hospitals who transferred patients versus those who didn't transfer patients? You did mention a couple of the reasons for transfers. And if you could elucidate any other reasons for transfers, yeah, that's a very important slide. And finally, And I think this slide shows it. What's the average distance of a patient transferred and what's the range of distances? Thank you again for presenting an excellent paper.
Thank you for those comments and questions. I will try to address them all, but please remind me if I forget one. So the difference between hospitals that are transferring patients and not transferring patients isn't entirely clear from the data we have. We did present preliminary results of this study at a statewide meeting that's well attended by a lot of community surgeons in Wisconsin. And the feedback and commentary that we got there was very interesting in that many brought up factors other than surgeon and patient discussion that influence the decision to transfer patients or not. Namely, one surgeon brought up that nursing staff was sometimes uncomfortable taking care of patients under 18, and she was told that she couldn't operate for that reason. Sometimes it's a blanket hospital policy. Sometimes the surgeon isn't even hearing about the patient, and the emergency medicine physician is making the decision to transfer. So I do think that it's definitely multifactorial, but we're working on narrowing down those reasons and getting to some of the cause of this. I also think it's important to note that the initial data suggests that many of these institutions selectively transfer patients, so operate on some children, but not all of them, and those are really the institutions that we're looking more deeply at understanding the rationale for who they transfer and who they don't. As you pointed out, the distance traveled in Wisconsin is oftentimes considerable between the site and where they're traveling to. I'm sorry, was there one more question in there? No, okay, thank you.
I think we have time for 2 quick questions. I know there's a lot of people at the microphone, but Dr. Darcy, you were first, Dr. Barnhart, second.
I think you were first. David Rothstein, Seattle Children's, great talk. I wonder if you had a chance to look for any of these potential confounders. Time of day, day of week, perforation rates, imaging, maybe an ultrasound that couldn't see, therefore transferred, and lastly, medical comorbidities that may have been an impediment on the anesthetic risk profile. Thanks for the talk.
Thank you. Unfortunately, the data set that we have isn't granular enough to look at the time of day or day of week when the transfer occurred. And as far as comorbidities, we also don't have a good way of capturing that data. In terms of perforated versus not, there's no code for that. We did do a subset analysis looking at charges after the initial date of the appendectomy to try to figure out if the length of stay or treatment of a more complicated appendix might be some of the reason for those charge differences. And the difference still held when we only looked at charges the day before or day of, within 7 days before the operation, excluding those charges afterwards. But we don't have a good, clean way of assessing that out.
Short question, short answer, please.
Yes, just maybe a short question and a comment. I think this issue of perforated versus non-perforated is essential in understanding whether this data really indicates what you say it does. And I think you need to have some model where it's either length of stay or ICD-10, right? Because if you're comparing non-transferred, non-perforated appendicitis to transferred complicated appendicitis, it doesn't show any difference other than the transport cost. So I think you need to come up with some surrogate way, either length of stay or another means to show us that. The other implied question is, do you have differences between the children's hospitals in terms of cost? Do you have more than one children's hospital in the state of Wisconsin, and is there a difference in the cost and performance between the two centers?
Thank you. Like I said, the data set isn't granular enough to look at perforated versus not, but we do know that the cost difference is not due to length of stay from doing that sensitivity analysis, excluding charges after the day of procedure. We do have different children's hospitals within Wisconsin. The 4 stars are where pediatric surgeons operate in Wisconsin, and we certainly can look at differences between charges for those hospitals, and thank you for that. That's a great next step. Thank you.
Thank you very much. Next paper is Practice Patterns in Esophageal Atresia Surveillance, a multi-center retrospective review from a regional consortium presented by Dr. Elizabeth Hughes from the Connecticut Children's Medical Center Hospital.
Am I able to see the slides?
Let's see. Did it change it? Yeah. See if we can go under, see if I can click on PowerPoint to see what that. Let's just go present a view.
I think I'll just do it.
Are you okay? Yeah.
Good morning. Thank you for the introduction and for the opportunity to present this work on behalf of the Eastern Pediatric Surgery Network. I have no disclosures. So I don't think it's advancing.
Can you click the, yeah. It's a green motion. Move forward, there you go.
We performed this research to evaluate esophageal surveillance practices in patients with esophageal atresia. It's important because it will add to evidence-based approaches for the complex, longitudinal, and multidisciplinary care of this patient population. Patients with esophageal atresia require lifelong follow-up care. Many experience increased acid exposure, which can lead first to esophagitis, then intestinal metaplasia or Barrett's esophagus, and ultimately malignancy. It's been reported that EA patients have a 4 times higher risk for developing Barrett's compared to the general population. We know that EGDs can detect both active and silent esophageal disease. National guidelines from 2016 recommend acid suppression in all EA patients under 1 year of age, 3 time points for endoscopy screening before adulthood, as well as multidisciplinary and standardized care. The EPSN published results of a study that found surgeons and gastroenterologists agreed with these guidelines, but there was poor adherence. From this, we hypothesized that not all EA patients are receiving surveillance, and for those who are, surveillance strategies may not be in accordance with these guidelines. This identifies the need for a larger scale review of surveillance and outcomes to optimize care. Our primary aim was to perform a multi-institutional and multidisciplinary review of surveillance practice patterns in patients with esophageal atresia. Secondary aims were to characterize esophageal disease, outcomes including pathology, post-op outcomes, loss to follow-up, and to analyze risk factors in this population. I see, now it's synced. We had 15 participating sites across the eastern seaboard. Number of entries per site highlights the range in volume across these children's hospitals. Data was collected through a web-based database capturing detailed information on EA patients cared for at these sites between 2018 and 2023. In reviewing over 500 records, our demographics were similar to what has been reported in the literature. Most commonly, primary anastomosis was performed, followed by staged repair. Acid reflux was diagnosed in about half of patients. Most were discharged from their index hospitalization on antacid medication, with reduced use over time, followed out to 10 years of age. 10% of patients underwent fundoplication, and 11 underwent pH impedance testing with a 54% detection rate. Of all patients, 80% underwent at least one upper endoscopy. Of those who did not undergo endoscopy, 67% of those patients were 5 years or older, and 81% were 3 years or older. Surgeons perform more endoscopies overall, but gastroenterologists perform more surveillance endoscopies.
The most common indications for endoscopy were symptoms, such as reflux, vomiting, dysphagia, followed by stricture management. Only 10% of all endoscopies were performed for surveillance, at which time 76% of those patients were without symptoms. Overall, we found that surveillance endoscopy occurs at an older age. In regards to biopsies during endoscopy, we saw that not all surveillance endoscopies took biopsies. This is a potential opportunity for standardization. Overall, a significantly higher proportion of surveillance endoscopies took biopsies when compared to non-surveillance endoscopies, and there were typically multiple biopsies per site. Rates in detection of esophagitis were similar in surveillance and non-surveillance endoscopies. Presence of eosinophilic esophagitis was about 20% in each endoscopy group. There were 2 patients with Barrett's. Both were identified on surveillance endoscopy. In conclusion, we found evidence to support our hypothesis that the technique of and age at surveillance was inconsistent and did not always include biopsy. While a majority of children had at least one upper endoscopy, a minority were for surveillance. Prevalence of Barrett's esophagus was low, but our work demonstrates that surveillance is key. Prevalence of eosinophilic esophagitis was slightly lower than has been reported in the esophageal atresia population, and there were no cases of malignancy. Our work continues with additional analysis of over 800 records and prospective data collection with standardized templates and a unified surveillance approach. This will ultimately allow us to contribute meaningfully to further development of evidence-based standardization of care for children with esophageal atresia. Thank you, and I'd be happy to take any questions at this time.
We have time for one question. Then I'll ask a question. Do you know who actually is doing the surveillance endoscopy? Is it a pediatric surgeon or is it gastroenterologist?
Yeah, so across our cohort, there is a generous mix. It is kind of split between the two. Overall, more surgeons are performing endoscopies, but that's probably due to endoscopies in this population that are being performed for dilation, and stricture management. But we did find that the gastroenterologists were performing more of those surveillance type endoscopies.
Thank you very much.
Thank you.
Our next paper will be presented by Dr. Allison Lehane from Northwestern. She will be discussing balancing sustainability and safety, reducing HVAC cycling in operating rooms without increasing infection risk.
Thank you for the opportunity to present. We have the following funding disclosures. Climate change, propelled by atmospheric greenhouse gases, is a global public health crisis. The healthcare sector is responsible for 10% of all U.S. greenhouse gas emissions and continues to lag behind other economic sectors in sustainability reporting. In fact, if the U.S. healthcare sector were ranked as its own country, it would rank 11th worldwide in greenhouse gas emissions. Energy most abundantly comes from burning fossil fuels, which is the largest source of greenhouse gas emissions. The operating room specifically is the most energy-intensive and waste-producing area within the hospital. Heating, ventilation, and air conditioning, or HVAC systems in ORs are energy-intensive and designed to maintain a high rate of air exchange to keep a sterile environment. The purpose of this study was to reduce HVAC cycling rates to the lowest industry standard to save energy, thus reduce our environmental footprint, while balancing surgical site infection rates as a key patient safety metric. To do this, a quality improvement intervention was conducted at a large urban freestanding single-center children's hospital with multidisciplinary team collaboration, including surgery, infection prevention, and facility engineering. The intervention involved implementing reduction of HVAC cycling rates to acceptable industry standards in April of 2024. The American Society of HVAC Engineers states that for operating rooms, The standard is a minimum of 20 air changes per hour based on prior research and modeling. SSI rates were monitored using standard infection surveillance protocols, including longitudinal run charts. Using negative binomial regression analysis, we compared the level and trend of SSIs between pre-intervention and intervention periods. Energy usage, as well as cost savings, were calculated to assess annual environmental and economic impact. Across all 22 of our ORs at our institution, the HVAC cycling rates were decreased from a median baseline of 32.8 air changes per hour to 20.7 air changes per hour. Rates prior to HVAC setbacks ranged from 22.9 to 33.5, and after the intervention, a much tighter range of 20.1 to 21.2. We assessed SSI data at our year prior and a year after our setbacks to ensure we were able to adequately assess not just rate, but also trends of SSI, utilizing negative binomial regression model to understand if our intervention affected these rates. Here we show a graph of SSI rates for all wound classes, with the dotted line representing the intervention time of HVAC setbacks in April of 2024. There was no statistically significant difference in the level or trend of SSI incident rate between the pre-intervention and post-intervention periods, with p-values of 0.8 and 0.9 respectively. Here we show SSI rates by wound class. Though there is an expected variability, primarily in our contaminated and dirty cases, we again showed no significant difference in the level or trend of SSI incidence rates between the pre- and post-intervention periods in any and all wound classes. There was a decrease in energy consumption with a projected annual savings of just over 500,000 kilowatt hours. This energy savings would result in a projected cost savings of over $40,000 annually. To further place this into perspective, the potential energy savings from 1 year of HVAC setbacks at our single institution is equivalent to charging over 27 million iPhones. Another way to qualify this amount of energy savings is through miles driven by an electric vehicle, with the average EV using 0.346 kilowatt hours per mile. Thus, 500,000 kilowatt hours saved is equivalent to a little under 1.5 million miles, which is then equivalent to driving an electric vehicle from Chicago to Montreal 1,704 times. In conclusion, reducing HVAC cycling rates in ORs can significantly decrease energy consumption and generate cost savings without compromising patient safety, as demonstrated by our stable SSI rates and trends. Thank you, and I'm happy to take any questions.
If not, I have a question. Your hospitals seem to be functioning with higher cycles than necessary. Most hospitals I've worked in like to function as cheaply as possible. Do you think this is just a lack of understanding or a lack of, like, why do you think that was happening? And do you think it's happening? How many other hospitals do you think that's the case for?
Yes, I think that there's definitely a lack of knowledge about this, and folks that aren't directly involved in both sectors, which is the facility engineering as well as the hospital leadership, don't always look at this information, especially at hospitals that perhaps have the funds to not have to worry about such things as cost savings. And so I do think that there are probably other hospitals out there that are operating at higher than needed HVAC cycling rates, and this sometimes comes from them seeing a SSI uptick artificially for a month or two, and so they bump up their rates and then never kind of turn them back down and don't really get to the bottom of why those SSI rates are going up in the first place, thinking that the HVAC cycling may fix that. So speaking with your hospital leadership as well as facility engineering can help bring everyone together to make sure we're not hurting the environment or our pockets.
I think we have time for one more question.
Hi, Richard Glick from New York. Thank you for this, because there's so little data out there, and because we're receiving pretty bad pushback from our engineers and things to talk about that there would be more infection rate, like you're saying, and you showed they're not. Just remind me of those p-values again. Were they significant?
They were not statistically significant, so 0.8 for rate and 0.9 for trends.
Right. I get it. Was anything looked at, and can you look at HVAC setbacks with respect to temperature? Because we're also receiving pushback on that, saying that the equipment has to be at a certain temperature. It can't be that low to keep its sterility, if you will.
Absolutely. I definitely think we haven't looked at that particularly ourselves, but our facility engineer is very passionate about this, and I think we could get together and certainly understand exactly what temperature at which is appropriate to maintain sterility.
Yeah, our facility engineer is not very enthusiastic about it, so thank you so much.
Sorry to hear that.
I'm sorry, I think we're going to have to move on to the next paper.
Thank you.
You very much. Next paper is postoperative prophylaxis use and outcomes in children undergoing non-emergent colorectal surgery. It's presented by Dr. Carrie McKee, who is a research fellow at Boston Children's.
Thank you for the opportunity to present our work. We have no disclosures. Consensus guidelines recommend against the use of postoperative prophylaxis in elective colorectal surgery. However, use of postoperative prophylaxis is common in pediatric colorectal surgery, and these procedures account for the greatest relative burden of postoperative prophylaxis use within pediatric surgery. This practice has been driven by a lack of rigorous comparative effectiveness data in the pediatric population. Addressing this knowledge gap has potentially important public health implications to optimize infection prevention or antimicrobial stewardship, depending on the relative benefit of postoperative prophylaxis. With these considerations, the primary goal of the present study was to compare the rates of surgical site infections in children undergoing non-emergent colorectal surgery who did and did not receive postoperative prophylaxis. To accomplish this goal, we conducted a retrospective multi-center propensity matched analysis of children who underwent non-emergent colorectal procedures over a 3-year period using NISQIP pediatric data. Exclusion criteria included emergent cases, use of intravenous antibiotics for suspected infections prior to the procedure, medications or comorbidities associated with immunosuppression, procedures documented with a contaminated or dirty wound class, inadequate antimicrobial prophylaxis coverage for colorectal organisms, and other non-colorectal procedures performed during the same operative encounter. Outcomes data from the NISQIP pediatric general participant use file were merged with prophylaxis data from the surgical antibiotic prophylaxis participant use file. The general participant use file includes a broad array of patient-level and outcomes data, including 30-day postoperative surgical site infection, readmissions, and reoperations. The surgical antimicrobial prophylaxis participant use file includes data on the type of prophylactic agent used, administration timeline, and duration of use. To compare outcomes between groups of patients who did and did not receive postoperative prophylaxis, we first used propensity matching to balance groups on covariates plausibly related to either a higher likelihood of receiving postoperative prophylaxis or developing an SSI. The association between the use of prophylaxis and outcomes in the propensity matched groups was then explored using chi-square tests. Overall, more than 1,500 patients undergoing non-emergent colorectal procedures were identified for propensity matching. The median age at operation was 8.9 months. Nearly 40% were female. 2/3 had an ASA class of 1 to 2, and nearly 20% of cases involved neonates. The most common procedure group included in the analysis was anorectal malformation repair, followed by pull-through for Hirschsprung's disease, diverting ostomy, with the most common indication being management of idiopathic constipation, and colostomy closure. 30% of all procedures were performed via a laparoscopic approach. 7% of all cases were considered urgent, and the median operative time was 133 minutes. All patients received prophylaxis prior to incision, with the most common prophylactic agent being used is Suboxetine. More than 60% of all patients received postoperative prophylaxis, with a median duration of just over 23 hours. The distribution of patient characteristics in the two comparison groups before matching is presented in this slide. In the unmatched cohort, patients who received antibiotics were more likely to be younger, more likely to have a higher ASA classification, and less likely to be receiving nutritional support. The distribution of operative characteristics before matching is presented here. Patients who received antibiotics were more likely to have a longer operative time within each procedure group. to be diverted at time of anorectal malformation repair or pull-through for Hirschsprung's disease, and less likely to involve a laparoscopic approach. In the propensity-matched groups, including nearly 400 patients in each group, no differences remain between groups in any patient characteristics nor operative characteristics. Following matching, no clinically or statistically relevant differences were found in surgical site infection rates between groups. Similarly, no differences were found for rates of reoperation nor hospital readmission. The results of the study must be considered in the context of its limitations. Data were retrospectively collected, and errors in misclassification of exposures and outcomes are possible, despite the measures used by NSQIP to ensure data integrity. Hospital-level identifiers are not available in the NSQIP pediatric participant use files, therefore limiting the ability to adjust for event clustering among hospitals. Finally, the analysis was limited to NSQIP pediatric hospitals, which may limit the generalizability of the results to other hospitals. In conclusion, the majority of children undergoing elective colorectal procedures receive postoperative prophylaxis, although this practice was not associated with improved outcomes. This exploratory analysis provides the rationale for an ongoing study by the Eastern Pediatric Surgical Network, which will evaluate the impact of postoperative prophylaxis across all gastrointestinal procedures while adjusting for hospital-level effect. Thank you for the opportunity to present our work, and I'm happy to take questions.
Paper is open for discussion for one question.
Great study, great idea. The most common reason I think is surgeon comfort in terms of why they do it, and the data has never supported it. But are you going to take it to the next level and like subset out people that do some type of bowel prep? Like you mentioned, it doesn't control for the adjuncts that might actually be reducing the SSI rate in one or another group.
Sure, thank you so much for that question. So our work with the Eastern Pediatric Surgery Network is really going to allow us to look at different SSI rates and actually trend of prophylaxis utilization across hospitals, which will really allow us to get down to sort of practice variation among hospitals, which we weren't able to account for in this study. Thank you.
Thank you very much.
Thank you.
Our next presentation will be by Dr. Jordan Rook from UCLA. He'll be discussing homicide at home, an analysis of national child firearm-related deaths.
Thank you. Firearm-related injury is the leading cause of child and adolescent mortality in the United States, with homicides accounting for most deaths. In pediatric homicide prevention research, we often focus on community gun violence and mass shootings. However, there's a facet of the ongoing gun violence crisis that is rarely discussed: homicides at home. Buried in a recent publication is a striking fact. Up to 1/4 of child firearm homicides occur at home. I want to reinforce that these are not unintentional firearm discharges or suicides. These are homicides, when a child is murdered in his or her own home. To prevent these cases, we must define the problem, and this is where research is lacking. We don't know which children are dying, we don't know the household conditions that precipitate these deaths, and we don't know the policies that may prevent them. Thus, we use national data to define the epidemiology of in-home child firearm homicide and to identify factors associated with these deaths. This research is the first step towards implementing policies aimed at preventing these tragic cases. We conducted a retrospective cohort study using the National Violent Death Reporting System from 2020 to 2021. Cases were linked with sociodemographic data from the US Census Bureau. We included child and adolescent victims of firearm homicide. Our outcome was death at home versus death outside of the home. We assessed household demographic and social factors. We conducted bivariate analyses and additionally multivariable logistic regression. Overall, we identified nearly 2,200 pediatric firearm-related homicides, with 1/4 occurring at home. When we broke this down by victim age, the proportion of children killed at home was markedly higher for younger children, with nearly 2/3 of firearm homicides among children 12 and younger occurring at home. In the figure on your right, the black line represents total firearm homicide deaths by age, and the gray dashed line represents the proportion of these deaths occurring at home. You can see that homicides account for an outsized proportion of deaths among younger children. Now, what is unique about these cases? On bivariate analyses comparing children killed in-home versus out of the home, in-home homicide victims were younger and more often rural residents, while boys and black children accounted for most deaths both in and out of the home. They represented a smaller proportion of in-home homicides. Regarding social factors, in-home homicides were more often linked to child abuse and intimate partner violence, with at least one of these factors present in at least one of 3 cases. Parent assailants accounted for 1/4 of in-home homicides. Comparing child versus adolescent victims of in-home homicide, these unique social factors were amplified among younger victims, with significantly higher rates of child abuse, intimate partner violence, murder-suicide, and parent assailants among children 12 and younger. Lastly, as surgeons, when we discuss child firearm deaths occurring at home, we often focus on unintentional firearm discharge and suicide. However, we found that 1/3 of all firearm-related deaths occurring at home were homicides. This includes a majority of deaths up to the age of 12, after which suicide becomes the leading cause. This is depicted in the figure with age on the x-axis and the proportion of firearm deaths due to homicide in black, suicide in yellow, and unintentional firearm discharge in blue. In summary, 1/4 of child victims of firearm homicide die at home. This includes nearly 2/3 of children 12 and younger. These cases were precipitated by unique factors, including intimate partner violence, child abuse, and murder-suicide. Tragically, these homicides were most often committed by parents. Through these findings, it becomes clear that traditional home-based injury prevention, which typically focuses on safe firearm storage, is not enough to prevent these deaths. Thus, we must turn our attention to laws that remove firearms from high-risk households. Extreme risk protection orders, colloquially known as red flag laws, are a promising solution as they enable law enforcement, and in some states, family members, to obtain an order restricting an at-risk individual's access to firearms. These laws have been passed by 21 states. Domestic violence relinquishment requirements vary by state, but similarly mandate firearm removal from individuals subject to domestic violence offenses. Thus, policies designed to protect parents, particularly mothers, may also protect children. Lastly, linking CPS cases with mandatory firearm removal could prevent homicides that escalate from child abuse. Our future work will assess the effectiveness of these policies and in turn advocate for policy change. In conclusion, in-home firearm homicide is a major cause of pediatric mortality, particularly for younger children. As we work to prevent these deaths, pediatric surgeons can be powerful advocates for change, not only through advocacy at the state and local level, but also by screening for risk factors, particularly child abuse, that may allow for the removal of firearms from high-risk households. Thank you, and I'll take any questions now.
Dr. Gaines.
That was a beautifully presented and really important study. My one question is, do you have any information on the assailant? Were they known to the child? Mostly, were they known to the child? Thanks.
Yeah, absolutely. So this data set's terrific. It links medical examiner, coroner reports, and law enforcement data. There is some missingness with regards to the assailant. It's about 30 to 40% in these cases. But for the ones that we're able to identify, overall it's about 40% of cases the parent was the assailant. And about 10% it's a sibling, typically an adult sibling. And then the third leading assailant was actually an intimate partner of a parent, which is where we are capturing some of the intimate partner violence associated cases. So yes, we do have pretty good data on assailants, and they are typically known to the victim.
Good. John Drouse, Jacksonville, Florida. I always look forward to learning new things at this meeting. This was sad information, but important information, and thank you for sharing it. I just really have a comment that when you go back to your home institutions, Please realize that forensic evidence should also be collected while we're trying to save these kids' lives. With gunshot wounds in child abuse victims, clothing, bullets, things like that are really, really important, and they need to be done importantly in the correct way. So please, I would just encourage everybody to review that with their home places.
That's an excellent point. Thank you so much.
Thank you very much.
Thank you.
We're going to Outcomes of Pediatric Ganglioneuroma, a pediatric surgical oncology research collaborative study presented by Dr. Matthew Parrish from the Mayo Clinic.
Either the mouse or
both. Actually, I think mouse works.
mouse. Okay, very good. Good morning, everyone, and thank you for this opportunity to share our work on behalf of the Pediatric Surgical Oncology Research Collaborative. My name is Matthew Parrish, as I said, and I'm a current general surgery resident at Mayo Clinic in Rochester, and we have no disclosures. Neuroblastic tumors, as we all know, exist on a spectrum with their treatment as well as kind of their histology, right? And so there is an indolent course, though, within the benign disease, with surgical resection remaining a hallmark of therapy. However, recently, with this known benign indolent disease, watch and wait strategies have been proposed. However, no current consensus guidelines exist. We know that there's varying practices across institutions, and that has pointed out all the more importance that we understand the clinical outcomes and implications of surgical resection versus observation in patients with benign neuroblastic tumors. To do this, we used multi-center data to try and aim to characterize the clinical management of ganglioneuromas in these patients and look at outcomes based on final treatment strategy of either surgical resection or observation. So to do this, we, like I said, conducted a multi-center retrospective review of 26 participating PSORC institutions. We looked at patients age 0 to 18 from January 2012 to December 2022. That it had an initial preliminary diagnosis of ganglioneuroma on pathology, or at least suspected. We excluded patients that had incomplete pathology reports, as well as any patient that had presumed malignant histology on their pathology report. We ultimately wanted to look at our primary outcomes of death, disease progression, as well as disability. To do this, we initially created cohorts, initially based on initial treatment strategy of either observation versus surgical resection, and then we collected various clinical, pathologic, and outcomes data, and then ultimately looked at them as far as their final treatment strategy of either surgical resection or observation. So this is our patient management pathway. As you can see, we had 275 patients. Ultimately, 11 patients that had planned surgical resection were actually eventually had surgical resection, and then our patients who had an observation, there was 2 patients that switched over from surgical resection to observation. And once again, we looked at their final outcomes based on their final treatment strategy. And so when we look at our cohort characteristics, we can see that we had a median age of 10.5 years old, and no difference really between planned observation or surgical treatment. We had varying smattering of genetic predisposition syndromes, although quite rare in our instances, and there was really no significant family history as it related to this as well. Most patients presented symptomatic, with the most common presenting symptom being a palpation of abdominal mass. However, nearly a third of patients were actually incidentally found for workup for some other varying process that they presented to with. When we looked at our specific tumor characteristics, about half of them were within thoracic cavity and the other half were roughly in the abdominal cavity. There was a smattering percentage of elsewhere within the abdomen. And now when we looked at our, like I said, the presumed pathology, most patients did have ganglioneuroma. There was a few patients with ganglioneuroblastoma intermix, and then there was one patient that actually turned out to have ganglioneuroblastoma nodular. When we looked at, again, tumor characteristics and workup, we saw that majority of patients did not have calcifications on a CT scan. And when an MIBG scan was actually performed, which was only performed in 99 patients in this, within our study, while a majority of patients were not avid, we did find that close to 40% of the patients within the planned observation cohort actually had an avid scan, and roughly 42% had an avid scan within the surgical cohort as well. Now, when we looked at planned observation versus surgical resection and looked at their image-defined risk factors, Not surprisingly, patients who were planned for observation were more likely to have an image-defined risk factor, and this was especially evident when it came to vascular encasement. Now, when we moved past and we looked at our final surgical pathology, so we ultimately of the 223 patients that had final surgical pathology, like I said, vast majority, over 90%, kept that diagnosis or had their diagnosis confirmed as ganglioneuroma. However, there was approximately 2% of patients that actually had an upgrade in their histology to either ganglioneuroblastoma nodular or neuroblastoma, unfortunately. And so then, now we've taken, like I said, we looked at those final outcomes over a median follow-up of 37 months. These are our raw percentages. We had any postoperative complication was close to 30% in our cohort. The most common complication was Horner syndrome for these patients. And then when we looked at their status as the last time they were followed, most patients were alive without evidence of disease. There was 9 patients within the observation category that had final treatment observation that had no evidence of disease. I don't quite have an explanation for that. But once again, the majority of the patients were alive with no evidence of disease. There was no differences in disease progression or long-term disability based off of final treatment strategy. So then when we looked at we coupled disease progression and survival, within the first 2 years, there was really no difference between the patients who had observation versus surgery. And not surprisingly, as you get further out, the patients who underwent surgery were more likely to be alive without evidence of disease. And like I said, part of this time to event analysis and the reason the figure looks this way, once again, was those 9 patients who actually had resolution of their disease. Now, there have been characteristics that have been described that all point to benign disease, and one being presentation at older age, CT without calcifications, as well as lack of MIBG avidity. Now, when we looked at these characteristics and we applied them to our cohort, our majority of our patients presented at an older age at 10.5 years old. 2/3 of our patients had no calcifications on CT scans, and when performed, roughly 60% lacked avidity on MIBG scan, once again, pointing towards that benign disease and supporting some of these characteristics of ganglioneuroma. So, with that conclusion, we found no difference in progression, long-term disability, or recurrence based on our final treatment strategies. Once again, with a rate of approximately 30%, there's significant surgical morbidity that still remains with surgical resection of these tumors. There is going to be a small percentage of patients that have, unfortunately, some pathology discordance, although, like I said, it's a very, very small percentage, approximately 2% when what we can find. Future direction and aims of this study where we need to take into account prospectively evaluating and applying potential observation criteria are needed. And one thing to potentially consider as well when it comes to some of these prospective criteria would be a small window of watch and wait, or saying a time to observation prior to surgical resection to see how the patients progress. And with that, I want to give thank you to our institutions, and we'll take any questions.
Papers open for discussion.
Thank you. This is a really important paper, Sharif, Emile, Montreal, because I really believe this is an area where significant practice change can occur. You're aware that there was a UK experience published just earlier, which almost is identical to this. But these two large experiences all include biopsies. Now, I think the potential practice change is you have a child, any of us can encounter a child like that next week, gets a chest x-ray for a fever and a cough, and you find a paraspinal tumor. You do an MRI, you confirm that this is a neuroblastic or neurogenic tumor, MIBG is non-avid, markers are negative. What is the rationale for doing anything surgical for this child? Because I'm observing a number of children for years who have presented exactly like that. Not even a biopsy was done, none of them needed any surgical intervention. So I'm just curious about your perspective on that. I know this doesn't address that in this paper, but I really would promote, and I've been trying to create this practice change in my group, that leave the children alone. They don't need anything. They've probably had this for years before we found out about it.
Yes, thank you for that question. To kind of allude to a little bit of that too, in looking at this research and our numbers, I can say that a lot of these biopsies are not always created equal, and some of the patients who had biopsies and then found later to have a little bit malignant histology or such, so not all are created equal, but that goes to beg the question again, like you were asking, is why go forth and try to intervene in something that, like you said, they've lived with. For us, we had 11 patients, for instance, who were planned observation that switched over to surgical resection, and it was for symptoms, and which I know that the UK paper again talks about symptomology management as well. But beyond symptom management or an increasing symptoms, I can see that, and I think that is worth reasoning. Even if you find it and the patient has no symptoms, once again, whether you want to biopsy or not, we could implement or think about saying, well, like you said, well, let's just watch and see, and keep an eye on things, and as long as markers stay the same, as long as your course is directed how it has been, like you said, I would lean to why start to intervene if it's going to be, especially with morbidity at the rates that it is.
Gilchrist, Brooklyn. I just want to emphasize it's the bravado of the non-combatants who want to jump into these cases and take these tumors out. If you don't have to do it, and you don't have any indication to do it, stay away from it. When we came up, we were taking all of these out, all of us. And it is very difficult surgery, and you can get into a lot of trouble. So those of you who are junior and haven't done many of these, I would say be very, very careful.
Yes, thank you for that.
Thank you.
Thank you.
Our next paper is going to be presented by Dr. Jeanette Jolie. She is a research resident at Texas. She'll be presenting impact of timing of inguinal hernia repair on neurocognitive outcomes in preterm neonates.
Good morning, and thank you for the opportunity to present today. We have nothing to disclose. The hernia in preemies or HIP trial is a randomized clinical trial conducted between September 2013 and January 2023 at 39 centers that evaluated the rates of serious adverse events and hospital lengths of stay between infants who underwent early compared to late inguinal hernia repairs, with early repair performed prior to NICU discharge and late repair performed after NICU discharge at greater than 55 weeks postmenstrual age. The late repair group had a 97% Bayesian probability of fewer serious adverse events and an 82% Bayesian probability of shorter hospital length of stay compared to the early repair group. An a priori secondary aim of the HIP trial was to evaluate neurocognitive outcomes. The secondary aim was planned in the setting of many mainstream news sources in the 2000s and early 2010s reporting on a growing narrative that general anesthesia may negatively impact the neurodevelopment of pediatric patients. Preclinical studies demonstrated a dose-dependent relationship between early exposure to general anesthesia and neurotoxicity. However, no randomized clinical trials had been done at that time demonstrating this trend in humans. Since then, the GAS trial was published in 2019, which compared the effect of general anesthesia to awake regional anesthesia in older infants with no difference in neurodevelopmental assessment scores appreciated by age 5. Another study from 2019 compared neurodevelopmental scores of term infants who underwent general anesthesia for pyloromyotomy with those of healthy controls, and found that general anesthesia was associated with lower cognitive scores by age 3. These studies begin to inform anesthetic effects in infancy. However, there continues to be no data on the effect of timing of anesthetic exposure on neurodevelopmental outcomes. Therefore, the secondary study aim of the HIP trial was to examine the impact of timing of general anesthetic exposure between infants undergoing early versus late inguinal hernia repair on neurocognitive outcomes. We hypothesized that late repair would be associated with a 6-point improvement in cognitive scores on the Bayley Scales of Infant-Toddler Development 3rd edition. Neurocognitive outcomes were evaluated as part of routine care using the Bayley assessment at 22 months corrected gestational age, which is an accepted method of neurodevelopmental assessment, scoring cognitive, language, and motor function. We focused specifically on the Bayley Cognitive Composite Score, for which the mean score is 100. No to mild impairment is a score greater than 85, 1 standard deviation below the mean. Moderate impairment is 70 to 84, between 1 and 2 standard deviations below the mean. and severe impairment is a score less than 70. Patients were grouped based on trial assignment to either the early or late hernia repair strategy, and comparisons were performed using descriptive statistics and univariate analyses. During the study period, 282 infants underwent inguinal hernia repair, 85 of which received follow-up with the Bailey assessment, 41 in the early repair group and 44 in the late repair group. Patients who received the Bailey assessment were largely similar to those who did not, with similar median gestational ages at birth and postmenstrual ages at enrollment. However, patients with the completed Bailey assessment were notably different in that they had lower median birth weight, more frequent inborn hospital status, and lower rates of grade 3 or 4 intraventricular hemorrhage. In those with Bailey assessment, group demographics were similar in gestational age at birth and sex, but different in birth weight, which was lower in the early repair group. At time of inguinal hernia repair, groups were different in postmenstrual ages, weights, and rates of leaving the OR intubated. But importantly, the duration of operative time between groups was similar. There was no difference detected in overall Bailey cognitive composite scores between the early and late repair groups, with mean scores of 84 and 83 respectively, and with the vast majority of individual infant scores falling below the standard mean score of 100. Based on cognitive scores, both early and late repair groups were majority no or mild impairment at 54% and 61% respectively. Moderate impairment was present in 29% of the early and 14% of the late group, and severe impairment was present in 17% of the early and 25% of the late group. In conclusion, general anesthesia exposure at a median postmenstrual age 42 weeks versus 59 weeks was not associated with a difference in Bailey cognitive scores. It is important to understand and to highlight that while scores were not different between groups, the overall cohort mean Bailey cognitive score was well below the standard mean score, indicating the vulnerability of this population. The poorer cognitive outcomes, along with the only 30% of our cohort receiving the Bailey assessment, present an opportunity to improve follow-up care for preterm infants who require surgical intervention with general anesthesia. From the HIP trial, we have a rich data set containing additional neurodevelopmental outcomes, including Bailey language and motor scores, as well as incidence of cerebral palsy, among others. And we look forward to using this data to further explicate the effect of variable timing of general anesthesia exposure on neurodevelopmental outcomes for preterm infants. Thank you.
Ulutoyi, Columbus, Ohio. Very nice work and nicely presented. We've done some work also in the preclinical realm, really looking at the fact that not just the anesthetic exposure, but repeated anesthetic exposure can actually contribute to these outcomes. As rightly pointed out in your group, or in this cohort of patients, they already had other risks, but in your analysis, you actually look at how many of these had repeated anesthetics, as opposed to just a single one related to the inguinal surgery.
I'm sorry, there's an echo, so I didn't quite hear that.
How many of these patients had repeated anesthetic exposures besides just the one associated with the hernia repair?
That's a great question. So with the HIP trial, patients were excluded who needed additional surgeries at the time of the hernia repair or prior to it. So I can tell you that because of the original trial, there were few exposures prior to that incident, but in terms of afterwards, I don't have that data. But it is an important thing to look into, and that was specifically noted in the FDA statement that was made in 2016 that there is an increased risk of anesthetic exposure with kids. So it is important to be aware of, so thank you.
Were you also able to tell which centers, was there a cluster of centers that was doing the follow-up well? Because that could potentially lead to an interesting quality study.
Absolutely. So it was very interesting. We did have a few centers that were definitely the contributors to the Bailey assessment, and specifically those that weren't able to complete the assessment. And there's probably a lot of factors for that. One of them, namely, is that this is an expensive test to perform, and a lot of insurances actually don't cover it. And that can affect whether or not, unfortunately, it is done at certain places or even offered. And so this trial in and of itself was funded because of the primary outcome and not because of the secondary aim that we evaluate today. And I think if we were to create a study in the future with this as the primary outcome and with potential funding to support all infants getting this assessment, we would have better data and more complete data to determine a more generalizable outcome.
My question goes in the same direction. With the 30%, you have 70% that were not screened. Someone might argue, do you know whether there's a difference in the non-screened group that you can pick up because you don't screen them?
So we do know the demographic differences between those two groups. We're able to look at that, but because we weren't screened, we don't know if there are necessarily outcome differences between those two groups. But that is notably a drawback of this, and we use this study in the secondary aim as primarily a exploratory finding, because we're not, this was not the primary outcome of this study, and because of that, we're not prepared to make a conclusion, but these exploratory findings are helpful to inform next steps and future studies as well.
Thank you.
Thank you.